Next slide. No, next slide. Yeah. It's coming on. All right. Today I'll be talking about meconium aspiration syndrome, and I am Dr. Maheshwari, professor in pediatrics. So this is an important newborn topic. So it is important both in your practical aspect as well as in your theory. It might be a short note. And coming to the topic per se, meconium is a Greek word called mekonai, meaning poppy juice or opium. It is a viscous dark green fecal material that accumulates in the fetal colon throughout the gestation, composed of intestinal epithelial cells, lanugo hair, mucus, and intestinal secretions such as bile. So normally the passage of meconium occurs within first 24 to 48 hours after birth, and the passage of fetal meconium resulting in meconium stained amniotic fluid occurs in approximately 12% of all the deliveries. So this is basically a fecal material that contains approximately the epithelial cells, lanugo hair, mucus, and the intestinal secretions such as bile. So if there is a delayed passage of meconium, that is after 48 hours, then you have to think of conditions such as congenital hypothyroidism or surgical conditions such as Hirschsprung's disease. So it has to be noted. Next, coming to the other aspects of meconium aspiration syndrome. So here are the risk factors. So risk factors, gestational age, it is very rare before 37 weeks of gestation. So it is common in term and post-term babies, like around 44 weeks or more than 40 weeks. And the risk factors are intrauterine distress, like placental insufficiency, maternal hypertension, eclampsia or pre-eclampsia, oligohydramnios, and maternal drug abuse. So these are the common risk factors. So I want you people to remember, like the most commonly affected are term and post-term. Preterm, it is very, very rare. So don't commit the word meconium aspiration syndrome in preterm babies. Now coming to the difference between meconium aspiration versus meconium aspiration syndrome. So meconium aspiration means presence of meconium below the vocal cords. It is just the presence of the meconium alone. So it does not necessarily mean that the child has developed meconium aspiration syndrome. So next, coming to the meconium aspiration syndrome. Meconium aspiration syndrome is nothing but when there is presence of meconium below the vocal cord and the child is presenting with symptoms of respiratory distress with radiological evidence of aspiration pneumonitis in the presence of meconium. So this we call it as meconium aspiration syndrome. That is presence of meconium with signs and symptoms of respiratory distress. All right. So next comes the pathophysiology. So what all happens when there is meconium aspiration? So the thing that is, first thing is, it can cause mechanical obstruction. Sometimes there can be mucus also in the meconium. So that can cause mechanical obstruction, or if it is a thick meconium stain liquor, again that can cause a mechanical obstruction. So this can lead on to pneumothorax, pneumomediastinum, and pneumopericardium. So these are the mechanical obstruction consequences. Next is chemical pneumonitis, primary or secondary persistent pulmonary hypertension. So this is one consequence of chemical pneumonitis, and surfactant inactivation can lead to diffuse atelectasis. So this is one thing I want you people to remember. So pathophysiology can be either because of mechanical obstruction, chemical pneumonitis, and surfactant inactivation. So these three can lead on to the syndrome called as meconium aspiration syndrome. So this will tell you what exactly happens when there is a passage of meconium. So first what happens is physiological passage of meconium, then meconium stained liquor. So this meconium stained liquor when the child aspirates after birth or in utero, there is meconium in the lungs. So either because of chemical pneumonitis, surfactant deactivation, or airway obstruction, all these can lead to MAS. And MAS can be either mild MAS, moderate MAS, or severe MAS. Mild MAS, the consequence can be hypoxemia. Moderate MAS, either there is hypoxemia and hypercapnia, means there is also carbon dioxide retention. In severe MAS, there is hypoxia, hypercapnia, and acidosis. There is oxygen, lesser amount of oxygen saturation, increased carbon dioxide levels, as well as whenever there is increased carbon dioxide levels, it predisposes to acidosis. So this you can detect by arterial blood gas analysis. Next, coming to the fetal compromise. So the passage of meconium, there will be continued fetal compromise and there will be pulmonary vascular remodeling. Because of chronic pulmonary vasoconstriction, there will be pulmonary vascular remodeling, which leads on to persistent pulmonary hypertension. So this is one thing, because whenever there is meconium stained amniotic fluid, it leads to aspiration, meconium in the lungs, and based on the pathophysiology and the severity, the symptoms vary. All right. So next, coming to the symptoms, there can be severe respiratory distress, and apart from that, there can be cyanosis, which will tell you that there is an evidence of severe respiratory distress, and expiratory grunting. Grunting is nothing but it is a noise because of lower respiratory tract obstruction. Then the other thing is alar nasal flaring, intercostal retractions, tachypnea, barrel chest in the presence of air trapping, and auscultated rails and rhonchi. So these happens in some cases. So these are the symptoms. Mainly it is respiratory symptoms, and in case it is severe respiratory distress, it is accompanied by all the other problems. Next, coming to the investigations. So these are the common investigations that we do. Arterial blood gas analysis, like metabolic acidosis, complicated by respiratory acidosis. Serum electrolytes, so there will be SIADH and ARR. And when you do full blood count, there will be hemoglobin and hematocrit levels may be lower, but it has to be kept sufficient so that to ensure adequate oxygen carrying capacity. So next is echocardiogram. Echocardiogram ensures normal cardiac activity and assesses the cardiac function as well as the severity of pulmonary hypertension and left to right shunting. So these are the investigations. So I come again, arterial blood gas analysis to rule out acidosis, serum electrolytes, full blood count, and echocardiogram. Echocardiogram will tell us the pulmonary artery pressures and the severity of pulmonary hypertension and whether there is left to right shunting or not. So coming to the chest X-ray findings in cases of meconium aspiration syndrome. So first is pneumomediastinum. That is, there is air in the mediastinal cavity. Here you can see there is air in the mediastinal cavity. So because the fluid is occupying the lung space, there won't be space for the air to be held in the lung parenchyma. So which will try to sweep out of the lungs. So that becomes either pneumomediastinum, pneumopericardium, or in general pneumothorax. The next is diffuse chemical pneumonitis. So here you can see this whitish opacities. So these are nothing but because of chemical pneumonitis, the lung parenchyma appears like this. And there is acute atelectasis. This means collapse of the lung parenchyma. So here you can see all the whitish shadows, which means the lung areas are collapsed because of mechanical obstruction. So these are the three things: pneumomodiastinum, diffuse chemical pneumonitis, and acute atelectasis. So these three clinical pictures will give you an idea along with the clinical findings. Like first there will be presence of meconium in the body. Then you confirm it by the presence of meconium in the vocal cord also. Meconium included the vocal cord. And those children presenting with respiratory distress, if you take an X-ray, you might get one of these pictures, and that will help you to know that child is having meconium aspiration syndrome. All right, so the next comes prevention. So prevention you do only when you feel after the routine suctioning of the oropharynx and the nasopharynx, that is routine intrapartum suctioning you do, delivered, all the children delivered following labor, complicated by meconium, and these are no longer recommended. But if suctioning can be done initially, then followed by your endotracheal suctioning. Endotracheal suctioning you do only if the babies are non-vigorous. That is, non-vigorous definition is either depressed respiration, depressed muscle tone, and a heart rate less than 100 beats per minute. If you can find out any of these, then it probably means the baby is non-vigorous baby. So in these cases alone, you do direct endotracheal suction. So this is reserved for non-vigorous infants. So I want you people to remember what is non-vigorous infants. So it is based on the respirations, muscle tone, and the heart rate. Now coming to the meconium, is the meconium present? So if it is no, then you go for the continue with the resuscitation. Like you clear the mouth and the nose from the secretions, dry, stimulate and reposition, and give oxygen as necessary. That is the usual thing that we are doing. Continuing with the usual resuscitation. Suppose if the baby is non-vigorous or there is meconium is present, so you do suctioning of the mouth first, nose, and then the posterior pharynx after delivery of the head, but before the delivery of the shoulders. After that, you see whether the baby is vigorous or not. If the baby is vigorous, then no problem. If the baby is not vigorous, then you do direct suctioning of the trachea and the mouth. So this direct endotracheal suctioning is indicated only if the meconium is present and the baby is non-vigorous. So I repeat again. So whenever the baby is born, so you see whether meconium is present or not. If the meconium is not present, then you go for the usual one. If the meconium is present, then you see whether the child is vigorous or non-vigorous. Then accordingly, you do the endotracheal suctioning. Now coming to the management. So management, you give oxygen by hood or positive pressure ventilation, or you, if needed, you give mechanical ventilation like oscillatory, high frequency jet ventilation, as well as PPHN like ECMO. In order to treat PPHN, you can give ECMO or inhaled nitric oxide. So these are the things that you do. So the major thing is oxygen, mechanical ventilation, and treat PPHN if it is present. So this is a next thing is about surfactant replacement therapy. Surfactant replacement therapy, if started within 6 hours after birth, improves oxygenation and it reduces the incidence of air leaks, severity of pulmonary morbidity, and hospitalization time of term infants with MAS. So this is about surfactant replacement therapy. Because there is surfactant inactivation by the meconium. So when we replace surfactant within 6 hours after birth, it reduces the complications related to the MAS. The other treatment that I want to tell is antibiotics. As such, there is no role for antibiotics, but in case secondary infection is suspected, then better to start antibiotics, or to prevent secondary infection, we start antibiotics. Then steroids. Steroids are usually not used these days because it prolongs the course of MAS. Another one controversial treatment is amnio infusion. So amnio infusion, actually it has failed to show an effect on the incidence of MAS or death. So this is after seeing all the journals, we have come to this conclusion. Even Cochrane review is telling the same thing. It's like amnio infusion is effective One journal says amnion infection has failed, but Cochrane review is telling that amnion infection is effective in reducing the incidence of MAS. So if it is a thick meconium stain, then probably you can go for it. The controversial treatment I already told you. So it is related to antibiotics we can give to prevent any secondary infection, and steroids are contraindicated. Then coming to the prognosis. So nearly all the infants with MAS have complete recovery of the pulmonary function, and children with MAS may develop chronic lung disease as a result of intense pulmonary intervention. So most of the time, all the infants with MAS have complete recovery. So there is no residual sequelae. But sometimes, particularly some children with chronic lung disease can have, because of intense pulmonary intervention done, like mechanical ventilation or treatment for PPHN, all this can lead to chronic lung disease. Infants with MAS have a slightly increased incidence of infections in the first year of life because the lungs are still in the recovery phase. So this is another one problem. So since the parenchyma has been disturbed, damaged, so these kind of lung parenchyma are more prone for infections. So now coming back, to a fast recall. So I just wanted to tell you people, like meconium means it's a literally meaning poppy juice or opium. It is nothing but it's a dark fecal matter, and it is a nothing but it is a stool, basically fecal material, which has to be passed within 24 to 48 hours after birth. But sometimes it so happens that meconium is passed in utero itself. So that we term it as meconium aspiration. And if there is respiratory distress associated with this problem, then we call it as meconium aspiration syndrome. So risk factors I already told you. So infants born, particularly term and post-term babies, they are the main risk factors, with intrauterine distress being the other risk factors. So only presence of meconium. So only presence of meconium below the vocal cords means meconium aspiration. So this does not necessarily mean that there is meconium aspiration syndrome. If there is meconium aspiration syndrome, there will be respiratory distress with radiological evidence of aspiration pneumonitis in the presence of meconium. Next, coming to the pathophysiology, like I already told you, there will be mechanical obstruction, chemical pneumonitis, and surfactant inactivation. So, mechanical obstruction of the airways, it can lead to pneumothorax, pneumomediastinum, and pneumopericardium. Chemical pneumonitis can lead to primary or secondary persistent pulmonary hypertension of the newborn and surfactant inactivation. So, this can lead to diffuse atelectasis. So, this surfactant inactivation is one reason we give surfactant replacement therapy in cases of MAS. Mechanical obstruction leads to many other complications, including atelectasis and pneumothorax. Chemical pneumonitis is actually sterile, but in order to prevent secondary infection, we give antibiotics when needed. So this I already told you, like depending upon the meconium in the lungs and the severity of the pathophysiology, the symptoms will vary, and when the symptoms are persistent, the lungs goes into vascular remodeling and PPHN. Symptoms are predominantly respiratory, like cyanosis, end expiratory grunting, LNSL flaring, intercostal retraction, tachypnea, barrel chest in the presence of air trapping, auscultated rails and rock height. So cyanosis, you people already know how to make out bluish discoloration of the oral cavity, the nose, and the lips. This is secondary cyanosis. And end expiratory grunting because of lower airway obstruction. Alanasal flaring, which means there is increased work of breathing. Intercostal retractions again means increased work of breathing. Tachypnea in normal newborn. Tachypnea, the respiratory rate normal newborn is around 30 to 50. So anything more than 60, up to 60 can be taken as normal. Anything more than 60 is taken as tachypnea. In barrel chest, in the presence of air trapping, auscultated rails and bronchitis in some cases. So these are the findings in cases of severe respiratory distress in meconium aspiration syndrome. So I am repeating for all those who are not attentive earlier. So kindly take notes. Whatever slides I am telling is important. If there is any doubt, kindly stop me to ask the doubt. Next, coming to investigations like arterial blood gas analysis. So metabolic acidosis complicated by respiratory acidosis. Serum electrolytes we can do sodium levels, and for acute renal failure we can do potassium levels, blood urea, serum creatinine. Full blood count like hemoglobin and hematocrit levels, and it may or may not be abnormal, but still it has to be kept in sufficient levels to ensure adequate oxygen carrying capacity. Echocardiogram ensures normal cardiac structure and assesses the cardiac function as well as the severity of pulmonary hypertension and left to right shunting. So this can measure the pulmonary artery pressure as well as it can assess the cardiac function and structure. So that way echo plays a very important role. So once we make out pulmonary hypertension, then the treatment varies accordingly. Chest X-ray, as I already told you, there can be pneumomediastinum, diffuse chemical pneumonitis, or acute atelectasis. Pneumomediastinum is nothing but there is air in the mediastinal cavity. Diffuse pneumonitis, you can see the lung parenchyma is uniformly affected. So there is whitish opacities that you can see. And acute atelectasis, there is collapse of the lung. There will be lung collapse. So these three are the telltale features that the child is having meconium aspiration syndrome. Pneumomediastinum, there can be pneumopericardium or even pleural effusion, diffuse chemical pneumonitis and atelectasis. If we can pick up any of these findings, then we are more on track of meconium aspiration syndrome. So always correlate clinically. So the child will be either term or post-term, that is one thing. And in the delivery room, if you ask, the meconium will be, amniotic fluid will be stained with meconium. That is another evidence. Then if you take the clinical examination, there will be respiratory distress and chest X-ray will confirm your diagnosis. All right. So if you're having any doubt, kindly let me know. So this is about the prevention. So endotracheal suctioning is reserved for non-vigorous infants. So non-vigorous is nothing but based on the heart rate, respiratory rate, and the muscle tone. Like heart rate less than 100, muscle tone will be decreased, and respiration also will be decreased. So routine suctioning. Suppose if the child is meconium stained, then routine suctioning can be done, followed by endotracheal suctioning if the baby is non-vigorous. So this is one thing I want you people to remember. Do endotracheal suctioning only for those babies who are non-vigorous, not for all the babies. For all the babies, it is even if it is meconium stained. If the baby is vigorous, do the usual routine resuscitation and then come back. Don't do endotracheal suction. Do it only if the baby is non-vigorous. So before going into the controversial treatment, I'll just tell you the protocols for meconium staining. So if there is no meconium staining, then go for the usual resuscitation, like clearing the mouth and nose from secretion, drive, stimulate and reposition and give oxygen as necessary. So if there is meconium stain, then you do suctioning of the mouth, nose, posterior pharynx after delivery of the head, but before the delivery of the shoulder. And suppose if the baby is vigorous, then go for the routine treatment. Suppose the baby is not vigorous, then you go for suctioning of the mouth and the trachea. All right. So coming to the management part, so you give oxygen as needed. So either by food or by positive pressure, I like CPAP. Then you can also give mechanical ventilation if necessary. Like there are various types like oscillatory, high frequency, and jet ventilation. And if at all there is PPHN, that is when you do your echocardiogram, you will come to know the pulmonary artery pressure, and that will guide you with the treatment like ECMO or inhaled nitric oxide as needed. So that is the treatment for your MAS. Then one more thing is antibiotics to prevent secondary infection. As such, it is not needed. Suppose if you feel the child is having any features of sepsis, then you go ahead. Surfactant replacement therapy. So surfactant replacement therapy is a newer modality. So it is started within 6 hours after birth, improves oxygenation and reduces the incidence of air leak, severity of pulmonary morbidity and hospitalization time of term infants is definitely reduced with MAS. So because there is surfactant inactivation, in cases of MAS, surfactant replacement therapy has been considered and it is proven to be useful by many studies. Coming to the controversial treatment like amnio infusion. Amnio infusion, according to one journal, it has failed to show any effect. But in Cochrane review, it has been concluded that it is effective in decreasing the incidence of MA. So where there are facilities to do amnio infusion, it can be done. So this is one slide I wanted people to copy down and remember it as well. So this is the protocol that we follow. When meconium is present, what do you do? When meconium is not present, what do you do? If it is not present, go for the usual protocol. If it is present, do the usual resuscitation and further action depends on whether the baby is vigorous or not. All right, so next coming to the other treatment about antibiotics. Antibiotics, suppose if there is any secondary infection, then you can give antibiotics, and steroids have no role in the treatment of meconium aspiration syndrome. Now coming to the prognosis. Nearly all infants with MAS have complete recovery of pulmonary function. Children with MAS may develop chronic lung disease as a result of intense pulmonary intervention. So infants with MAS have a slightly increased incidence of infection in the first year of life because lungs are still in the recovery period. So always remember MAS, meconium aspiration happens in term and post-term babies, and if just the presence of meconium alone does not mean that the child is going into meconium aspiration syndrome. The presence of respiratory distress along with the investigations and radiological findings has to correlate, and then you confirm the diagnosis and then go ahead with the treatment along with the clinical scenario. Treatment, like I've already told you, oxygen is most important, and depending upon the respiratory parameters, mechanical ventilation, and the other things are antibiotics if you suspect secondary infection. So otherwise, the prognosis is not bad. Like most of the children improve unless there is severe MAS. Most of the children do improve. So if there is any queries, please let me know. Let me put the important slides for you people to copy down. So kindly copy down this slide. Once you've taken a note of it, kindly let me know. What happens after passage of meconium and if the amniotic fluid is stained with meconium? This is a flow chart. This is a diagrammatic representation which is more easier to remember. Kindly take a note of it. All right, then we'll move on to the next important slide. This is another important slide. If meconium is present, what do we do? If it is not present, what do we do? If it is present, what do we do? I've already told you, so kindly take a note of it. If it is not present, do the routine things. If it is present, again do the routine things followed by check whether the baby is vigorous or not. If it is vigorous, then usual resuscitation. If it is not vigorous, endotracheal suction. Kindly let me know after taking a note of the slide. All right, all those who have taken a note of it. If there is any queries, please let me know. All right, if there is no queries, then we'll wind up the class.